Good morning. My name is Laura Hungerford, and I'm an infectious disease epidemiologist from the University of Maryland in Baltimore. I'm a co-lead for this session with Amir Sapkota, who's an environmental epidemiologist from University of Maryland College Park. Welcome to this session, which is the panel on climate change and health in Maryland. And thank you for your participation in this session and especially in the discussion here and that hopefully will follow with future collaborations. Today's topic is especially timely for this Public Health Week, with the White House's focus on this topic as they've been discussing this week. Our keynote speaker, Dr. Caldwell, set the stage for this discussion and emphasized the scope of the change and also in the area of infectious diseases. When we consider, however, public health in research in Maryland, her points resonate in the context of our local diseases, both on, on land and also involving water, which is such a prominent feature for our state. When you think about the future, I'm sure everyone has seen the ice melt projection maps, and even in less extreme scenarios, you can see the impact that this would have on Maryland's habitat, both for animals, vectors, and for humans as well in our social landscape. So for this panel, our goal is to first complement Dr. Caldwell's presentation through an emphasis on non-infectious public health challenges that accompany climate change. Secondly, we want to bring the focus to Maryland, particularly to highlight areas for increasing public health research on climate change that all of us can collaborate in. So the speakers that we have for you to lead this off before the panel discussion will be Clifford Mitchell from the Department of Health and Mental Hygiene, Jennifer Martin from the Baltimore City Health Department, and Amir Sapkota from here at the University of Maryland in College Park. Their presentations will be followed by an open discussion of opportunities for future research in Maryland and beyond. So with that, I'd like to introduce our first speaker. Let me pull up his slides for you. Who is Dr. Clifford Mitchell. He's the Director of Environmental Health Coordination as well as the Preventive Medicine and Public Health Residencies at the Maryland Department of Health and Mental Hygiene. He has an MPA, he has a BA from Williams College, an MS from MIT, an MD from Case Western Reserve, and an MPH from Johns Hopkins University. He was on faculty at Johns Hopkins University, and he is now the Director of Environmental Health Coordination. He coordinates environmental health issues at DHMH, including environmental public health tracking, monitoring algal blooms, coordinating with state and other health agencies, and he leads the state's strategy for public health and climate change. As we hear from him, please visualize how your own research or research interests may offer collaborative opportunities with his initiatives. So, Dr. Mitchell.
Thank you, Laura. Good morning, everyone. It's a pleasure to be here. Can you hear me in the back? If so, nod appreciably. Okay, good. So it's a pleasure to be here this morning. I feel a little bit as though I'm coming home, although I did actually attend another institution somewhat to the north of here for my MPH. That's because this one wasn't granting an MPH at that time. Otherwise, I'm sure I would have been here. And thank you for that very gracious introduction. What I'd like to do this morning is talk a little bit both about the federal and state efforts on climate change as they relate to public health, share with you a little bit about what we're doing at the State Health Department, talk a lot about the collaboration that's going on between the University of Maryland and the Department of Health and Mental Hygiene and local health departments across the state. And I want to do so in a way that capitalizes on the fact that it is Public Health Week nationally, and the emphasis is on climate change. It's been a somewhat strange week for me. Actually, it's been a very strange week for me. So on Monday, I was at the White House at the old Executive Office building for a day-long meeting on community resilience, mental health, and climate change. One of the really interesting things out of that meeting was the discussion about how when we talk about climate change, a lot of the discussion around climate change has been talking about it's sort of the verbiage of disaster, or the verbiage of doom, or the verbiage of bad things happening. And in some ways, one of the really interesting things to come out of that meeting was the importance to many, many communities and folks who are talking about climate change at the local level of not only talking about health data, and we're going to talk a lot about health data, but also about the importance of individual stories and the idea that climate change represents not just a threat, but the response to climate change can also be a positive. And so one of the very important things that I got of that discussion was the value of talking about climate change not just in disaster terms, but also in there are opportunities as well as risks in when we talk about the adaptation to what is actually going on now in terms of climate change. And on Tuesday, I had another interesting day. I had the opportunity to meet with a group to talk about climate change, and then to hear the President talk about the national response to climate change. And you have to give this administration a huge amount of credit for talking about climate change in a way that is providing both states and communities with resources and a framework for talking about and responding to the challenges of climate change. And that's some of what I'm going to talk about this morning. So I think building on Dr. Colwell's talk, which was very heavy in data and very heavy in science, what I'd like to do is build on that to show how that discussion of science and research can translate into state, community, and federal responses and adaptation to climate change, not just mitigation, but also adaptation. So Maryland, since for at least 8 to 10 years, actually, but before that, has been planning for climate change. And when I was at Hopkins at the School of Public Health, I had the opportunity to work with the Governor's Commission on Climate Change, which this institution was very much a part of, but as part of the working group that was looking at adaptation response, we talked about public health and what were the important parts of the public health response to climate change back then. We had a very small list of issues, and that list has grown since that time, and you're going to see that. But Maryland's state strategy, as it appears today, has two components. The mitigation part, which looks at reducing greenhouse gases, and then an adaptation response, the first phase of which is focusing on sea level rise and coastal storms. And then the second part is a broader response looking at resilience at the local and state level. And an important part of that is the emerging public health strategy for climate change. So the Centers for Disease Control and Prevention a number of years ago developed what's called the Brac Framework, which is building resilience against climate effects. And the focus here, if I can put my phaser on stun, is to look at using health data and climatic models to develop models of health impacts as we think that they might occur in the future in this region. So the focus is on using region-specific forecasts and regional health data and regional population data to understand and think about what are the particular vulnerabilities of populations here in the state and in regions of the state, and think about what the likely climatic effects might be, and then think about developing interventions that are focused specifically on those likely effects. So there's a component that is projecting the disease burden. We're going to talk about that a little bit. And then developing health interventions that are, as I said, are data-driven, driven by an understanding both of population and of forecast models, and developing those interventions in a way that can address what we think are going to be the likely impacts, and then implementing and evaluating these. And the CDC, in funding this work, has now funded 16 states and 2 cities to implement this framework. And here in Maryland, we are one of the recipients of that grant. We're now in year 3 of this 4-year grant. So the grant, as it was originally written, was a partnership between the University of Maryland School of Public Health and the Department of Health and Mental Hygiene and local health departments. And the goal was, as I said, to use regional climate change forecasts, and I'll talk about those in a little bit more detail, to develop vulnerability assessments for local health departments that they could then use on region-specific or jurisdiction-specific intervention programs, some of which already were in existence and they were building on existing interventions and health priorities. And in other cases, they're using the data to develop new interventions focused specifically around problem areas that they think might be affected by global climate change or regional climate change. And these disease burden projections are now some of the focus of the work that's being done by Dr. Sapkota and his group here. And we're going to talk about those data a little bit later on. And I think one of the important lessons that we're looking here at is how we are going to evaluate these interventions, particularly because one of the challenges for local health departments that I'm sure Jennifer Martin will talk about in more detail is that local health departments have to be able to respond to all kinds of hazards, not just those that are emerging at some point in the future. And so this has to be consistent with those efforts. So this is a schematic of the range of outcomes that we're looking at. We're looking at injuries and temperature-related health events, changes in respiratory diseases, in asthma particularly, but also in chronic obstructive pulmonary disease, waterborne illnesses and injuries, and this focuses very much on some of the work Dr. Caldwell is doing, looking at things like harmful algae blooms or non-cholera vibrio, which do exist here in the state, and I'll talk a little bit about those. Foodborne illnesses, and we're going to talk about that in a bit, and then vector-borne diseases. So as we sort of think about how to implement these, we're partnering with 4 jurisdictions, Baltimore City, Prince George's County, Washington County, and Wicomico County. And for those of you who are not Maryland natives, you will maybe not appreciate, but that represents really the breadth of geography represented by the state. So you've got Wicomico County on the shore, you've got Prince George's County, you've got Baltimore City in the middle of the state, and then you've got Washington County in the Piedmont area, where you've got a very different climate than you've got, and somewhat less influence directly of the Chesapeake, although still important contribution to the Chesapeake ecology. And the work that's being done here at the University of Maryland as part of this is to look at taking climate models, which have been developed here regionally, and then apply those to diseases and injuries that are of concern. And we are looking at the outcomes on the slide here, including infectious diseases like salmonella, respiratory diseases like asthma, and then we're also looking at injuries and thinking about, for example, motor vehicle accidents and other kinds of injuries. One of the big things that happens when you have a severe weather event is that you always notice not only do you have the sort of problems with heavy rainfall that Dr. Caldwell just talked about with the potential for changes in infectious disease, but you also have severe problems with injuries, and that includes not just physical injuries, but also injuries, for example, related to carbon monoxide poisoning, which we've all had recent reminders of is still a huge, a significant health problem. So the vulnerability assessment is has been done by taking essentially historical illness and injury data and looking at that data in combination with historic meteorologic data in order to then develop essentially a regression model which can be extrapolated using forecasts of, particularly in this case, temperature and rainfall. And in the case of conditions where we don't necessarily know exactly when the disease started, when the event started, you can use a negative binomial regression equation to describe the relationship between, for example, temperature or rainfall and the event. Or when the date is known, you can use a technique that's known as a case crossover analysis where each case serves as its own control. And these are two techniques that are used epidemiologically a lot when looking at the relationship between environmental variables or environmental influences and disease processes. So this is work that Dr. Sapkota and his group have been doing here at the school, in which they're taking salmonella cases. Now, salmonella is a reportable condition here in the state, and so if a case of salmonella occurs and is culture confirmed, that event is then recorded in the National Electronic Disease Surveillance System, which is the Salmonella and other infectious disease registry for infectious diseases here in the state. It's also part of what's called FoodNet, which is the active surveillance network that is actively not just looking at cases that are reported to it, but then going out and looking at the circumstances of those cases. And this is all work that's funded by the CDC at the Department of Health and Mental Hygiene. So what Dr. Sapkota's group did was to take 9,500 culture-confirmed salmonella cases, and in addition, myocardial infarction data. This is not an infraction, it's an infarction. My apologies for the edit there. But these are cases that are hospitalization discharges from the HSCRC, the Health Services Cost Review Commission, which are all hospital diagnosed or hospitalized patients with myocardial infarctions whose data occur in a registry which was provided to the University of Maryland group. So this is a way of looking at these data, and as I mentioned, you can either do this in a case crossover design or binomial regression design. Either way, the idea is that you are developing essentially a regression model in which you're looking at either extreme heat events or extreme precipitation events and regressing those against the event in either salmonella, an event of salmonella, or an event of a myocardial infarction, a heart attack, and then looking at the predictive power when controlling for other variables. And as you can see, if you look at the underlying incidence rate and then compare that with extreme temperature events, these are 95th percentile events for temperature or precipitation. You can look at seasonal variability. You can also look at cases that occur by different types of serotype. And this is all part of the underlying event to sort of separate out the effects of the various types of other contributing factors to understand which of these might be normal seasonal variability, but then controlling for those, look for those events that peak when you have a peak, for example, in the number of extremely hot days or the number of extremely wet days. So When controlling for these other factors, and this is a predictive model that looks at age, gender, race, ethnicity, season, and then geographical location, if you look at the incidence rate ratio for temperature, so these are extreme high temperatures, or the incidence rate ratio for precipitation, what you see in both cases is that there are statistically significant differences between these events when looking at whether or not you are on the coast or in a non-coastal environment. So coastal environments, obviously those abutting, these are geographic regions defined by how close they are in proximity regionally to either the Chesapeake or the Atlantic coast. And what you can see is in both cases there's a positive association when you have extremely hot days at the coast. You see a statistically significant increase for extremely hot days and for extremely wet days. This is not true when you look at non-coastal environments for the effective temperature. It is, however, still significant that when you have an extremely wet day, whether you're on the coast or not on the coast, an extremely wet day will be associated with an increase of approximately a little bit over, as you can see, about 5% here in the amount of salmonella that occurs. So this is a way of sort of looking at, just as Dr. Colwell was describing, it's a way of looking at an infectious disease process and understanding the contribution that climate or weather is having on the incidence of these diseases. We're still, however, at the point of John Snow, not knowing what exactly is the mechanism by which this happens, and we're going to talk a little bit about what those mechanisms might be. If you look and actually look at the incidence rate ratios here, again, you see about a 5% increase or a 7% increase when looking at the coastal counties, and in the non-coastal counties, you can see that this is not significant for extreme temperature, but for precipitation, there's still about a 3.5% increase in those cases, in the likelihood of a case on extremely wet days. So the effect, whatever it is, seems to be higher when you're closer to the coast. For myocardial infarction, again, you can see that if you look at areas that are and here there may be a different geographic issue involved, but here are two urban areas, Baltimore City, and then Maryland as a whole. If you look at the odds ratio of being hospitalized for MI with temperatures that are at the 95th percentile, you can see a significant risk of being hospitalized for an MI, that is to say of an MI event, hospitalization event, particularly large in Baltimore City when compared with either Maryland or these non-significant changes with the state as a whole. And I'm sure Jennifer can talk about this, but the heat island effect is one of those issues that obviously is a potential contributor. It may not be heat alone. It may also be associated with overall air quality, not just the heat effect itself. So as we are developing and thinking about the intervention strategies here, the use of these data is a way of informing and working with local governments and local health departments to think about what are their priorities already in dealing with these events, and how can we use the data that are developed here to develop intervention strategies that would be useful for local jurisdictions, jurisdiction-specific, or for the state as a whole in the case of the state health department. How can we think about using these data most constructively for purposes of thinking about the public health strategy in the context of the overall state strategy on climate change? One of the things that we have been doing with George Mason University is, and some of you in this room might even have received it at some point or the other, we are now entering the third year of a 4-year longitudinal survey of Maryland residents across the entire state on a regional basis on their attitudes regarding public health and climate change. We are the only state in the country that I'm aware of that's actually doing this, and this is a collaboration with Ed Maybach and Karen Akerlof at the George Mason University. And the results of this survey have been very instructive, because one of the things that they have shown is that here in Maryland, first of all, we are a little bit more receptive and aware of the issues of climate change than the state, than the country as a whole. But what's also interesting is that the most important and salient factor that seems to motivate a large number of people in terms of their response to climate change is specifically around public health and health issues. More than energy issues, more than sort of general environmental issues, public health and health seems to be one of the most important, if not the most important, motivating factor in having people of all generations, whether they're receptive to the idea of climate change or even not receptive to the idea of climate change. Health still seems to be one of the most, if not the most important, factors in terms of thinking about that message. So, the goal of this plan, then, is to continue to use the survey data, the data that are being developed through the work with Dr. Sapkota's group and the university here, and to make those data and the results of those analyses available to the public, not just the local health jurisdictions, but Professor Mitch Wong, who's part of the biostatistics group here in the School of Public Health, has been working with us now for, I think, more than 6 years to develop what is probably the most sophisticated data visualization, analysis, and reporting tool of any of the environmental public health tracking states, of which there are now 22 in the country. And Professor Wong's environmental public health tracking platform, which is a collaboration between him and us, and is now being used also in Kentucky, and we're also hosting some of the data from the District of Columbia, allows us to look at data both at a county level, and also now we're about to launch sometime probably this year with good fortune, sub-county level, a way of looking at health data and environmental data that allows us to basically calculate on an instantaneous basis, dynamically, the rates of disease and exposures across any geographic part of the state. This is particularly important because of the issue of health and exposure disparities. Because one of the issues that we are looking at very importantly is we know that this is not just an issue of overall public health response, but also response that is differentially affecting different communities and different types of people. So this is an important issue for environmental justice. It's an important issue for being able to serve all the populations of the state. And so just to finish up then, this is a truly, I think, unique collaboration between the School of Public Health, the Department of Health and Mental Hygiene, and the CDC. It's a way of using health data, but it's also a way, and I think it's an important way. I saw a friend and colleague, Barbara Kerbo, here in the audience a little while ago. It's very important for us to think about the role not just of the health data, but also of the individual stories as a way of sort of thinking about how do you get people to think about and respond to climate change in a way that is not just driven by fear, but is driven by an opportunity, if you will, or a recognition that as climate change happens, just as life is constantly changing, how do we respond to that in a way that doesn't paralyze people, but instead allows them to use data and to use information most constructively? And that really, I think, is the critical role that we're trying to play both here at the School of Public Health and in the state to allow people to do that. And I really want to thank my colleagues here, friends, former students. I feel odd saying that, but it's true, here at the School of Public Health, and also at the Department of the Environment, Dr. Jed Miller, the team at the Department of Health and Mental Hygiene, and finally the National Center for Environmental Health and the CDC for funding this work over the last 3 years in the case of climate change and since 2003 in the case of environmental public health tracking. And with that, I'm done.
All right, and we'll have questions at the end or after the session. I'm happy to introduce our next speaker, who will be Jennifer Martin. Jennifer is the Deputy Director of the Office of Public Health Preparedness and Response at the Baltimore City Health Department. She has a bachelor's in biology and anthropology from St. Lawrence University, her JD from the University of Maryland School of Law, and an MA in Security Studies from the U.S. Naval Postgraduate School. Following her degrees, she was an intern for the World Health Organization, a law fellow at the University of Maryland Center for Health and Homeland Security, and then served as a public health emergency planner before moving to her current position. She will talk about climate change and public health at the local level, where she's a national leader in developing responses that directly address public health challenges already currently occurring with climate change. And again, please contemplate her presentation through the lens of your research framework and future opportunities for collaboration.
Good morning, everyone. I'm very happy to be here today, and as has been mentioned, I would really appreciate it if everybody would kind of think about what I'm going to talk about today in terms of future collaborations, because we're very interested in finding ways to collaborate more with the university, to look more at data and to really analyze it and be able to implement some effective interventions when it comes to extreme temperature. So as mentioned, I am from the Baltimore City Health Department, and I work in the Office of Preparedness, Public Health Preparedness and Response there. And just to start off, I'm going to talk for a few minutes. Well, first I'll give you just an overview of my presentation. I'm going to talk for a few minutes about the role of preparedness and climate change. I'm going to give an overview of our city's Code Blue and Code Red programs. Those are our extreme cold and extreme heat programs that are implemented in Baltimore City. I'm going to talk for a few minutes about the summer of 2012, which was a very hot summer in Maryland, if you remember. And we'll look at some data trends associated with that. Talk a little bit about some of the challenges that we face in preparedness and implementing interventions related to extreme temperatures. I'm going to talk just for a few minutes about a pilot project that we're working on where we're really trying to get focused into the community more. And then talk a little bit about some things that you can do both as individuals and as academics. So just to start off, I'm going to talk a little bit about preparedness and climate change. So Cliff mentioned that public health departments are required to be prepared and ready to respond to a number of hazards, and those include infectious disease outbreaks, severe weather events, pandemics, bioterrorist events, as well as a host of other environmental crises and hazardous material events. So it's a really broad area, a lot to prepare for and train our health department staff on to be ready for. But in looking at preparedness and climate change, I just wanted to talk for a few minutes about the disaster risk management cycle. So this is sort of how preparedness looks at planning for and responding to events. So you'll see at the top there are risk reduction measures. So before something happens, what we can do to try and implement measures ahead of time to reduce the impact of different disasters. What are some mitigation measures? And some of those are things that happen from a zoning perspective, whether it has to do with whether or not areas are zoned for development or not zoned for development, and those types of things. In public health, these are measures like going out into our community, preparing individuals to have a disaster plan, have a disaster kit, and kind of know what the resources are in their community should an event happen. At the bottom is the crisis management section of our disaster risk management cycle. So when something happens, we respond to it, and then we recover. And as part of our recovery, we're going back and looking at the response, and we're looking at what went well, what didn't go well, what can we do to make improvements for the next time. So we go around in our cycle, and we come up with additional mitigation measures. I want to talk a few minutes just about vulnerability and vulnerable populations. So when we talk about disaster preparedness and emergency preparedness, and we talk about climate change, we often hear the terms vulnerability. Well, what does it mean to be vulnerable? When you look at any disaster that affects any of us, we're all vulnerable to that disaster. But the level of vulnerability fluctuates. I may not be as vulnerable to one type of disaster as somebody else. So it's a complex phenomenon, and there are a lot of factors that need to be considered. Specifically in talking about health, age, whether or not someone has a chronic illness or not, their access to health care, whether or not they are a substance abuser, these things all affect their vulnerability. And in the case of extreme temperature that we're going to talk about today, there are certain vulnerable populations that are more susceptible to extreme temperatures. And so some of those are the elderly, homeless, again, substance abusers, people who work outdoors, and we'll also talk a little bit about how isolation can be a real factor when it comes to extreme temperatures. So I'm just going to spend a few minutes kind of giving an overview of what our Code Blue program is. Again, that is our extreme cold temperature plan. It's a multi-agency coordinated plan. It involves not only the health department, but our Office of Emergency Management, our Homeless Services Office, Salvation Army, our Housing Department, and a number of other partners. This program is in place every year from November 15th to March 15th. And as part of the program, we monitor the temperature, and when there is severe cold, we make what are called Code Blue declarations. And so you can see our Code Blue declaration criteria. It is a very flexible system, but essentially we declare Code Blues when the forecasted wind chill is going to be below 13 degrees. A Code Blue declaration triggers several things. It triggers extended hours for our public and private homeless shelters in the city, and it also triggers expanded capacity at homeless shelters within Baltimore City. But in addition to these measures that are directed specifically at the vulnerable in Baltimore City, we also have other services that are in effect during Code Blue. So through our Office of Aging and Care Services, shelf-stable meals are delivered to elderly seniors in the city through Meals on Wheels, as well as a program called Eating Together. The Salvation Army is out in the community providing hot drinks and food to individuals who are on the street. We have stepped up energy assistance programs through the city that include no heat weatherization services, as well as connecting individuals to energy assistance through the state so that they can keep their power on and keep the heat on. Code Red is very similar. It also is a multi-agency coordinated approach toward dealing with extreme temperatures. It's in effect every summer from May 15th to September 15th. Again, we have flexible declaration criteria, but essentially our health commissioner will make a Code Red declaration when the heat index is forecasted to be 105 degrees or greater. We also do consider other conditions, such as it could be a lower heat index that is in place for a number of days without any relief, or other events. And we'll talk a little bit about that in our case study. Our Code Red declaration triggers several mechanisms. First of all, we open cooling centers around the city that are available to the public to come in and get some relief from the heat. Those cooling centers are air conditioned, and they also provide water to individuals who come in. We provide transportation to seniors to our cooling centers through our Office of Aging and Care Taxi Card program during Code Red declarations. And again, through our homeless outreach teams, the Red Cross and the Salvation Army, we're able to be out on the street providing water and services to the homeless. During the Code Red season, we also are out in the community, again, being very aggressive about energy assistance and getting individuals signed up who may have had their power cut off. A big part of Code Blue and Code Red is outreach and awareness. So we're targeted in on those vulnerable populations, but we're also getting messages out to the general public at large. And we do that through a variety of means, which include mass media, television, radio, et cetera, mass public communications. We have email alerts, different listservs throughout the city, Reverse 911, which is a system that the city can actually send out targeted phone calls to certain geographic areas based on a need to. We have a 311 system in the city where citizens can call for city services. During the Code Blue and Code Red season, they can call to get information about the homeless shelters, to get information about the cooling centers, about energy assistance, and all the things that we're trying to implement to assist people during extreme temperatures. We also use the 211 system here in Maryland, which is another public communication system where individuals can call to get more information. We try to do a lot of neighborhood outreach as well during Code Blue and Code Red seasons. A lot of that involves additional outreach through the existing city agencies, which include our housing department, the fire department, the police department. We also do messaging through our community emergency response teams, our CERT teams. And we do some social media messaging as well through Facebook, Twitter, and a system called Gov Delivery, which in some ways is probably familiar to your campus alert system. It's a system where we can send alerts out to the citizens of Baltimore City. However, individuals, when they sign up, they can also select other topic areas that they might want to receive information about, and Code Blue and Code Red are included in that. Data tracking, we do some data tracking with our programs. In the health department, we look at weather data, which includes temperature, wind chill, heat index, precipitation, and wind speed. We also look at heat-related and cold-related ED visits and heat-related, cold-related EMS calls, as well as heat and cold-related deaths. Our other agencies help us out by monitoring the calls that are received to our 311 call center to see how many individuals are calling and asking about either the extreme heat or the extreme cold. And that information is used to help us make determinations about whether to open additional facilities. We also are trying very hard to collect data related to the usage of both the cooling centers as well as the homeless shelters. Some of that data is, some of it is hard to collect because when individuals come into our cooling centers, they may also be in those locations for other services. So our cooling centers are primarily set up in our senior centers as well as in our community action centers, which are run through the Mayor's Office of Human Services. And so if you are an individual, you're going to a senior center or you're going to a community action center, you may be there to access other resources through the city. but while you're there, you may also take advantage of the fact that it is a cooling center. So sometimes we have some concerns about the data that we're getting from those centers, because we're not always entirely sure if people are there primarily for the cooling center or if they're there for other reasons. I'm going to talk now just for a few minutes about the summer of 2012, which was a very hot summer. And you may recall that it was the summer of something called the derecho, which is a line of severe thunderstorms that moved through Maryland and caused quite a bit of damage across the state, including in Baltimore City. So summer of 2012 was already a pretty warm summer even before that storm came through. It turned out to be the third warmest summer on record in the United States. And the 8-month period from January to August was actually the warmest on record ever. So when the derecho storm came through in late June, it had a lot of high winds and created a lot of power outages. And so in Baltimore City, our heat index exceeded 105 degrees, and we had approximately 100,000 people without power in the city. So during that derecho response time, we actually opened additional cooling centers. So we had a total of 22 that were opened across the city. Now normally on a code red day, there are 9 cooling centers opened up. So we more than doubled the number of cooling centers. We also were distributing water and ice, and that was part of the response to the storm, but as well a response to the extreme heat that we were facing. We had a lot of our CERT teams across the city activated, going door to door, doing a lot of targeted outreach, especially in the neighborhoods that did not have power, where we knew there were a lot of seniors and other vulnerable groups. We did a lot of reverse 911 calls, again, to those areas where we knew we had individuals without power and with needs. And then we also had some outreach that was done through our Mayor's Office of Neighborhoods and other groups that the Mayor's Office of Neighborhoods works with. And during that storm, we also had increased on-duty fire and EMS resources that were available. So that was in response to the heat, and also in response to the storm. And just, again, to kind of go back to Cliff's point about public health departments having to be able to respond to anything, it was a very busy time for our public health department. Not only were we engaged in all of these additional code red response measures, but we had disaster shelters set up across the city where we were providing nursing support and animal support. We had our environmental health teams out and doing a lot of inspections because of the power outages. And we were also doing a lot of tracking of our healthcare facilities. In Baltimore City, we have over 500 licensed healthcare facilities. Many of them did not have power, and that was a real concern. So we were doing a lot of outreach to them as well, helping to prioritize the restoration of their power. So there was a lot going on besides just the response to Code Red. Here is just a graph that shows our reported heat-related deaths during the period of the derecho. So again, that storm came through on June 29th, and the power outages lasted about a week, week and a half. And you'll see our heat index actually spiked up to 114 degrees in that week following the storm. And at the point of that 114-degree heat index, we still had over 20,000 individuals without power in the city. So there was a real need. Here is a graph that just shows some of the usage data from the community action centers. And this graph actually shows us 2011 and 2012. So remember, it's 2012 that was the derecho period. 2011 was also a very hot summer. Not as hot as that period after the storm, but still we had a lot of code red declarations that summer. And you can see that based on this graph, our community action centers are located sort of geographically across the city, and you can see the most usage that we saw was in the northern and the southern sections of the city. This graph shows the senior centers and their usage for the summers of 2011 and 2012. I'll just point out that that Sandtown Winchester Senior Center, that's located sort of in the northwest section of the city. So that is in keeping with the Community Action Center data. And the Zeta Center as well is a senior center that's located primarily in the northern western region of the city. Here's some of our heat-related ED data. So this graph shows heat-related ED visits for 2010 through 2014. And you'll see, as we would sort of expect, July being the hottest month in Maryland in general and in Baltimore City, we see the most heat-related ED visits in the month of July. And you'll see that in July of 2012, there was a pretty significant spike in the number of heat-related ED visits, which we would expect given that derecho and that period of power outages and extreme heat. Oh, sorry. I've been told to speed it up. So here's some EMS heat-related data. Again, for this, you'll see, again, that July is the month where we see the most heat-related EMS calls. And here's just a graph that shows some of our heat-related deaths by month and year. Again, you'll see that July, which are the red bars, is the month where we see the most heat-related deaths. And in 2012, actually, all of our heat-related deaths occurred in July following the derecho. This graph just shows really quickly some of our weather surveillance. At the top is actually last summer. And so you'll see last summer was a very mild summer. We actually only have one code red declaration the whole summer, and that occurred on July 2nd. And you'll see that the temperature and the heat index really didn't vary. They were very close. At the bottom is this past winter's data. And so you'll see that we had a lot of code blue declarations. We actually had 32 this past winter. And we had a number of days where our wind chill actually was below zero. So it was a very, very cold winter, a lot of extreme periods of cold. Some of the challenges, very quickly, that we're facing in the program is data standardization and underreporting. So we're trying to standardize the data that we're collecting from the centers. I mentioned that earlier. We also see underreporting when it comes to the cold and heat-related deaths. It's not very common to see that the primary cause of death for someone is heat or cold. And a lot of times it's not even listed as a secondary cause when we know that that probably is not the case. Getting the message out to the most vulnerable. Getting the message out to the most vulnerable is also a real problem. Human behavior, message fatigue, the built environment, and we can talk more about this in the discussion. We're doing a pilot project in the community, and we're looking to get more faith-based and nonprofit organizations to open their doors within the community because transportation to cooling centers is an issue. And then just really quickly, some things that you can do: be more heat and cold aware, be prepared. I wouldn't be a good preparedness person if I didn't push the make a plan, build a kit, help each other, and the see something, say something, which is not just, a suspicious package. It's if you see anything in your community that doesn't seem right, say something.
Thank you. Okay, good morning, everyone. And I think I thought I would have 5 minutes, but I think I have like 3 minutes of fame here. So please bear with me. So we're going to skip introduction here. I'm going to talk in the next few minutes about chronic diseases. Okay, so we have heard a lot about infectious disease this morning, starting with Dr. Rita Colwell's work. But what I'm going to talk about is, in the next few minutes, is chronic disease in climate change. And the one question that you may ask is, why chronic diseases? Well, in the westernized society, we have done a great job of treating people when they get sick. So people are living longer and longer. But oftentimes, that is with existing condition. So the question that we have is, what happens to those people that are already vulnerable and living with existing diseases? So the two examples that I'm going to use is allergic rhinitis, also known as hay fever, and asthma. And I'm going to skip through these introductory slides. Basically what it says is, the ragweed pollen production is much higher when it's grown under higher carbon dioxide concentration and warmer temperature. So that's basically the take-home message on this. I'm not going to go through that introductory slide anymore. And also that the ragweed pollen season is increasing, and that the increases is more pronounced as you go north towards our neighbor. Anywhere from 26 to 27-day increase in ragweed pollen season when you look at 1995 and 2011. But what I'm going to talk about is, how is that all related to chronic diseases such as hay fever and asthma? And as you know, hay fever is very prevalent. Some of you may be starting to feel it already. It affects around 7.5% of U.S. population, costing about $11 billion in U.S. economy annually. Asthma, on the other hand, impacts close to 26 million Americans, costs U.S. economy about $56 billion. So we did a study in, where we looked at the allergic rhinitis data from the National Health Interview Survey. And we take data from 1997 to 2013, so almost 17 years of worth of data. So we had about 500,000 U.S. adults on that population, of which close to 40,000+ reported having allergic rhinitis. The second set of results that I'm going to show relates to asthma data. It's asthma emergency room visit data. Okay, so these are much severe cases of asthma, and that's from Maryland Department of Health and Mental Hygiene. And on that, we had around 116,000 ER visits. And we linked those data with the extreme temperature and precipitation events, and we used statistical model to look at the relationship between increases in extreme temperature events and a risk of allergic rhinitis or a risk of asthma hospitalization. So what do we see? So this is U.S. nation as a whole. Like when you look at the entire country and compare those people that were at the highest quartile of exposure, meaning these are the people living in the county that experienced the highest frequency of these extreme temperature events. And you compare those to those living on the lowest quartile. So lowest quartile is always the reference group. And then we have on the x-axis, we have the odds ratio and 95 confidence interval. And what we see in the summary is that those people who were living at the highest, the area that had the highest frequency of these extreme temperature events, experienced something like 5 to 6% increases in risk of allergic rhinitis. And the interesting thing is that this was not uniform across the region or within the ethnicity. So if you look at, for example, eastern part of the U.S., you see the most signal in a non-Hispanic group. Not much going on in the non-Hispanic whites or non-Hispanic blacks. You do the same thing, same analysis repeat for the western part of the United States. Now you see very clear signal on the non-Hispanic whites. And you see signals in the Hispanic also, but it's not consistent. The third thing we look at is the timing of exposure. When did these extreme temperature events happen? And so when we look at that, what we see is the most consistent increases in risk of hay fever happens when these extreme events happen in the springtime or the wintertime. You see some signal in the fall or summer also, but it's not quite as pronounced as the one that you observe, for example, during springtime or the wintertime. So not all extreme temperature events are equal. And the risk that we experience varies across region and varies across ethnic subgroups. This final slide here, I guess, is now we are looking at the emergency ER visit data for asthma in Maryland. And what we see here is that 3% increase in risk of asthma ER visit in Maryland for 1 day increase in those extreme temperature events. And that also varies across counties, and it is also significantly much higher when you are looking at just the summertime events. So the point that I'm trying to make here is that, we see significant impact on health associated with these extreme temperature events. And the increasing body of literature has over the past decade has shown that we can expect these extreme temperature events, these extreme weather events, to be more frequent in the coming decades, as well as the intensity of these extreme events is going to be more frequent, much worse as well. So you do the math, okay? So I think I will, and this is just shows, some of the collaborative work that we are doing, and our idea is, really work with people that are on the forefront of all this, people like Jennifer, people like Cliff, so that we can have, this informed discussion about the impact of climate change on health, and that, yes, it's different. Climate is different than weather, and having a snowfall outside is not really an indication of climate change. With that, I think I will leave it and acknowledge all the hard work of particularly my doctoral student, Crystal Opperman, who did most of the hay fever analysis, and Dr. Jiang, Dr. Sonia, and Jared Fisher, and other collaborators.